All right, welcome back from the break. We are going to move on next and sort of veer away a little bit from surgical ICU care into using ultrasound in the ICU. And our local ultrasound expert, Dr. Rubin, is going to give us a talk on that.
Thank you very much, Dr. Frank. Thank you, everybody, for coming. So this talk will be an introduction to critical care echocardiography. And if you're already familiar with critical care echocardiography, I think there'll still be something here for you to help move things up a notch. Our objectives today are to introduce critical care ultrasonography, to demonstrate the utility of critical care ultrasound specifically when assessing shock. And as we go, I'll also clarify the distinction between basic and advanced critical care echo, as well as compared to comprehensive echocardiography. So my agenda is to share with you my 6-step approach to using basic critical care ultrasound for shock. And I tell you, it's not groundbreaking. And that's the point. I'll quickly go over some of the basic echo windows. So if you've seen them, it'll be a review. If you've never seen them, you'll become oriented to them. And then we'll go through some clinical cases. What I would say is that when you think about shock in terms of critical care echocardiography, sometimes in medical school or in training, we're taught to think about shock in terms of these broad buckets. That's not the approach I would generally use to think about shock when using critical care ultrasound, because all of these categories and the different things you see within them, they don't necessarily imply a specific management. Sometimes in both obstructive shock or hypovolemic shock, the answer is fluids, for example. And patients in the ICU very often also have multifactorial shock. And because of that, there's two, I think, levels to thinking about critical care ultrasound. The first is that critical care ultrasound can sometimes straightforwardly diagnose the cause of shock. You put on a probe and you find a huge pleural effusion, and you clinically assess together with that effusion that you've got cardiac tamponade. Right? So you put down your probe, you've made a diagnosis. And I would share that for people who are starting critical care ultrasound learning, the first thing to focus on really are the can't miss diagnoses that ultrasound will find for you. And I'll point out what I think those are. The second level is when you become more comfortable with critical care ultrasound, is where the ultrasound won't necessarily help you diagnose the cause of shock. And that's particularly helpful in cases of multifactorial shock where there are a few things at play. But using the ultrasound and your clinical skills, you can identify the most hemodynamically significant component of shock and use your ultrasound to guide management. And so it might not necessarily be able to put your shock into one of these buckets or even to one of these diagnoses, but it can still help you make the next best decision. And so that to me is actually the segue into discussing the differences between basic and advanced critical care echo. Basic echo is qualitative. You're going to get comfortable with the different windows, and you're going to learn what qualitative, perhaps even eyeball assessments you can make using your ultrasound, whereas advanced echo is more quantitative, and generally speaking, that will allow you to make finer distinctions. Basic echo, therefore, has 5 key views, where it's going to be important to understand when a view is on or off axis and what can and cannot be said from a particular view. When you become more advanced, there's really unlimited views, because even if your views are off axis, you can become comfortable knowing what you can or cannot say based on an off axis view. And therefore, I think basic echo will guide diagnosis and major management, and it'll answer the big questions. And most of the time, or very often, maybe won't answer any questions, and you'll put down your probe. Advanced critical care echo will allow you to guide complex management in these multifactorial hemodynamic states. So therefore, it has broader applications. You use diastology, and it might help you with some fluid management. You can assess native and prosthetic valves, pericardial disease, ECMO, mechanical circulatory support. And so it's really a spectrum between basic and advanced. For our fellows, I teach a course that I would call probably moderate, where it's somewhere in between, picking out the things that I think are helpful. I'll point out what some of those are too. So I'm not going to go over this slide in detail. You have the reference, but this is sort of a pictorial demonstration of the distinction between basic and advanced, right? A basic echo will say, is there severe LV dysfunction? An advanced echo would ask you about the filling pressures, and so on and so forth for these different categories. My suggestion for those who are new to critical care ultrasound, what I was referring to when I say that there are a few just can't miss diagnoses, or at least the basic things you should be able to assess early on in ultrasound, would be focusing on identifying 4 findings. So the first would be impaired LV function. Right? Of course, when you find impaired LV function, you have to determine whether or not it's acute or chronic, which is a clinical correlation. Impaired RV function with the same caveats. valvular regurgitation. You don't want to miss acute MR in the medical ICU. Very easy to do without an echo. And a pericardial effusion, which might be part of your diagnosis of cardiac tamponade. I think these are the things, if you're just learning critical care ultrasound, these are the first things to make sure that you're able to do. These are important things to determine and identify early, especially in a medical ICU, because they'll significantly change management from what you otherwise might assume or think was simply septic shock or some other form of vasodilatory shock. So how do you actually pick up the probe and go through a case and help determine or differentiate the shock that you have? So as I mentioned, I don't use these buckets necessarily to guide my approach. And if you look for algorithms for how to think about shock through the lens of an ultrasound, you'll find them. But these algorithms are more intended, in my mind, for the cerebral process that goes through what you should think, what your brain should go through, the thought process your brain should go through when you're distinguishing between different types of shock. But it's not a practical guide, because if you were to, let's say, follow this one on the left, you're ruling out LV systolic dysfunction, yes or no, you have to go through all the windows to determine that, right? And then if you want to see, well, do I think that there's an acute MI, you'd have to go back to other windows and maybe assess regional wall motion abnormalities together with your trope and EKG, et cetera. And so instead, I have my 6-step approach to shock, which I shared from the outset was not groundbreaking. In fact, when you hear it, it'll be probably intuitive, but it's actually, I think, important to say. And so I will. So the first step is to go through all the windows methodically. So for basic echo, these are the 4 to 5 basic views. Go through them intentionally, methodically, so that you don't have to keep going back and forth between them and you remain efficient. And as you're going through each window, you want to track findings that support various diagnoses. So in the back of your mind, you might have that algorithm, but you're thinking about the different things that you can and cannot see on the various windows. And I'm going to go through them briefly when we have our window review in just a moment. And then at the end, when you've gone through your windows, then you summarize, then you conclude that algorithmic brain process where you summarize your findings to reach perhaps a working diagnosis or maybe a working next step. And the other thing I would remind you is that while I'm focusing this talk today on echo, on the heart ultrasound, there's also benefit and value added in the extra cardiac assessment. If you're concerned about a PE and you know how to do lower extremity venous ultrasounds and you find a clot, that can guide your management. If you find B lines on your bilaterally on your lung ultrasound, that might clue you in more to a cardiogenic shock, et cetera. And then the final things that you do is you act. You make a management decision. You do something about what you found, and then you reassess the patient after you're taking action. And these final 2 steps, to me, are the most important in distinguishing critical care or bedside or POCUS ultrasound from comprehensive ultrasound. Because critical care ultrasound certainly does not replace comprehensive echocardiography. We're not cardiologists. We're not echocardiographers. Maybe some of us are cardiologists. But to me, broadly, comprehensive echo is more of an imaging tool. If you really need to understand what the aortic valve looks like, you need to get a good sense, maybe you have a congenital patient or in any patient, you have to get a good sense of what the pericardium is looking like or whether or not there's really regional wall abnormalities. That's something that you want to get a really high quality windows and a high quality echocardiographer or cardiologist to give you a report. Critical care echo, to my mind, is a monitoring tool. It's not continuous monitoring, it's intermittent monitoring, but this is something that is readily available to you if you can use it, because you can't get an ultrasound tech or a cardiologist to come do a comprehensive echo every 20 minutes when you want to make another change that you're doing based on an echo finding. So critical care ultrasound is real time. You have a focused assessment. You're going to guide immediate management decisions, and you can reassess on serial echo. And so a lot of what we look at will overlap with comprehensive echoes, not to as fine a degree, but some things that we would focus on might be a little different. So when you're thinking about volume responsiveness, or perhaps you're trying to assess cardiac output at the bedside, these are things that you might do more often through the critical care ultrasound lens than through a comprehensive echo. And so with that introduction, I'd like to take us through the basic windows. I'm not going to discuss image acquisition. I think that's best learned at the bedside. So we're going to be focusing on image interpretation. There are a lot of high quality and short, easy videos you can find on YouTube to review where to place the probe to get a specific window. So the first view that you have here when you're going through an echo is fairly standard to go in this order. This is the parasternal long axis view. So I said I won't talk about image acquisition, but parasternal just means your probe is just next to the sternum and you're pointing it to the right shoulder. This is the parasternal long axis view. And what you see here is the left atrium, and blood is flowing from the left atrium through the mitral valve into the left ventricle. And then the left ventricle is pumping blood right out through the aortic valve, which is here. And you are also getting a sense of the right ventricular outflow tract. So how do I know that this image is on axis and then I can make an interpretation from it? So you can see both valves sort of on plane. They're opening and closing nicely, you could see. And you also want the apex of the left ventricle to be off camera. If you were seeing an apex on camera, you're probably foreshortening. The image is probably not going to correctly help you assess LV function. And because you're seeing mostly LV here more than RV, most of the things you're going to be able to see here are going to be regarding the left ventricle. And when I'm looking at left ventricular systolic function, and this is a normal echo, this is taken from the ASE prototypical normal echo, most people sort of jump at what they would consider to be the EF, where you just sort of get a sense of like how much is being pumped out here. You should be very cautious about that because on just one view, I'll share with you there are 17 segments of the left ventricle. I like to joke that it's less complex than the lungs, which have 18 segments. The heart has just 17. You're only seeing 4 segments on this view. I'm not going to go through them here. That's a bit more advanced. But just to share, you're seeing less than 25% of LV function. So you don't want to make any call from one window for anything, but that sort of illustrates why you wouldn't want to make an LV function call here. But before you even look at how much you think this chamber is changing between systole and diastole, the other thing to focus your eyes on is how much is this wall thickening? This is the anteroseptal wall. How much is this thickening? This is the inferolateral wall. Is it thickening? You see with each systole, it's thickening nicely. Those are signs of good LV function. And the other thing you can look at is excursion, that longitudinal motion. Everyone talks about the RV as having longitudinal motion, and it's true, it's more pronounced in the RV, but the LV also has this longitudinal function that you want to look at. So I look at longitudinal function, it's called excursion, thickening, and also what you would call maybe the EF, what you might really call fractional shortening or fractional area change. You should also put color on these valves, which I'll show you. That's one of your first opportunities to assess for severe MR. This is all you're seeing up here of the RV. So what you can mostly sometimes see in someone who has a severely dysfunctional RV is you might notice that this is extremely large. We have what's called the rule of thirds, where the RVOT should roughly be the same size as the LVOT, as the proximal aorta here, and should be the same size as the left atrium. So if one of these is significantly larger than the others, it's probably enlarged. And if it's really large here, that might clue you into some RV dysfunction, but there's not much you can say about the RV. So again, here's a pictorial graph. You have this in your slides just to review what you're seeing: LA, LV, AV, RV, interventricular septum. So as I said, you can put color, you can zoom in if you want, you could put color on the mitral valve, and if you saw a large streak, this would probably be blue, because when you're looking at color Doppler, there's 2 colors, and we use the acronym BART, blue away, red towards. So that's relative to the probe. So any blood flow going away from the probe is blue, any blood going towards the probe is red. In this orientation, blood flow is sort of going perpendicular to the probe, but you've roughly got the net vector is away from the probe. So if you had serious MR here, it would be blue. It's an opportunity to rule in MR. I would never rule out MR from this view for that specific reason, because if it's completely longitudinal, that wouldn't be picked up by the echo. The echo is going to best pick up any change or MR that's going towards or away from the probe. So you can look for AI, MR. MR to me is the much more important finding to identify in the ICU, in the medical ICU. So that was your parasternal long axis view. Then you have the parasternal short axis view. And there are actually 4 levels to the parasternal short axis. On basic echo, we focus on the mid level, which is the papillary level, but I'm going to show you all 4: the aortic valve, the mitral, the papillary, and that should actually say apical level. And then the apex is its own finding. So here is the parasternal long axis view at the aortic valve level. It's the least intuitive view anatomically. You have the aortic valve here opening and closing. You can see here when the valve opens that it has this triangular shape. So it's a tricuspid, tri-leaflet aortic valve. Over here, you have the left atrium. Remember, you won't see left ventricle here because the left ventricle is below the aortic valve. So that's left atrium. This here is right atrium, so you have your interatrial septum. This valve is the tricuspid valve. The right atrium, the right ventricle actually goes a little bit higher than the aortic valve, so you're able to see some RV. And over here, you might be able to make out a little bit of a valve. That's the pulmonic valve. So blood flow is really going from the right atrium deep into the apex of the RV and then out the pulmonic valve over here. And there's an opportunity here to look for tricuspid regurg. Pulmonary insufficiency, these are a little bit more advanced. You can get an RVSP from this view as well. That's one view. If you see a completely calcified aortic valve, it might clue you into aortic stenosis, but I generally find that to be beyond the scope of pulmonary medical ICU critical care. If you move down one level, you get to the mitral valve. So it has this classic fish mouth appearance where you can see the leaflets, the mouth, the lips, the anterior leaflet, the posterior leaflet, opening and closing. And here you have the interventricular septum and the right ventricle. Most of what you can tell here would be also about LV function. And you can see that the LV is compressing inwards nicely. I generally like to put, eyeball a finger or look at the mouse in the center of the LV. And you can see that the walls of the LV are coming inwards towards the mouse. That suggests that there aren't potentially regional wall of motion abnormalities. If one segment wasn't coming in, that might clue you in. I also find that to be a bit more advanced. The main thing to look at is though that the LV is functioning, is contracting inwards. And again, here, you can look at thickening all around the left ventricle. We're at the base of the heart over here, and you can look for thickening along across the ventricular muscle all throughout. You might get septal flattening at this level in severe RV dysfunction where you get the D sign, which I'll have a case to show you. And it's not the greatest view to comment on RV size, but if you're able to see an RV that is outrageously larger than the LV, that might clue you into RV size as well, although that's going to be best assessed from the apical 4-chamber view. So interventricular septum, mitral valve, anterior leaflet, posterior mitral valve leaflet, RV. Moving along, a little bit lower, you have the papillary muscle level. You have 2 papillary muscles, and you're looking at the same things that you're looking at the mitral valve level, but you're one level lower. If you're thinking about segments of the, valve, there were 6 segments on this view of the mitral valve, 6 segments. You go down one level, 6 more segments. So now you've seen 12 out of the 17 segments, so to speak, of the LV, just again to give you a sense of how much of the LV you're covering from these different levels. Then you go to the apical level, 4 segments here. Same idea, you can look at thickening and inward movement. And if you go a little bit lower, you can see the apex of the heart itself, which is the 17th segment. The perhaps most important view is the apical 4-chamber view because you can see so much, but again, you always want to correlate your findings to things that you're going to see on other views. But to orient us here, over here you have the left atrium, you have the right atrium, you have the left ventricle, and you have the right ventricle. And you can see that you might be able to see that the tricuspid valve here inserts just a little bit more apically than the mitral valve. And that's how you know that this is right and this is left. Now, you also might be able to see that the left ventricle is larger and thicker, and those are usually features of the LV. But when you're determining whether or not your view or image is on axis, you have to have features that are true both in sickness and health. Because a seriously dilated and ventricularized and hypertrophied RV could also look like this. So you have to know that this is not RV some other way. And the way you know that is by seeing that the tricuspid valve leaflet inserts more apically here. This actually reminds me, I neglected to discuss, I'm going to briefly go back, how you know that these short axis views are on axis. And the general answer is that for the papillary muscles, you want to be able to see both. For the mitral valve level, you want to be able to see those 2 fish mouth leaflets that I showed you. And you generally want this to be circular as opposed to an oval. The only exception to the circularity is if you have the flattening of the septum where you have a D sign, because that again could be a sign of just disease of the right ventricle sort of pushing on the septum. But the rest of the LV, in almost all diseases, is nice and circular. So if you're getting an oval shape, you're probably at an oblique angle where you're catching a little bit of 2 different levels across the left ventricle. And so those are the ways to know that you're on axis for the short axis view. But coming back to the apical 4, you're on axis, you've got nice long ventricles with 2 atria. Some people describe this as the ice cream cone shape, where this is the cone and you've got scoops on the top. The apex should be right at the top of the screen, not off to the side. And as I mentioned, you know that right is not left because the tricuspid valve is inserting ever so slightly more apically than the mitral valve. It's probably easiest to see when the valves are closed. I think I'm going to have trouble pausing this, but if you notice when the valves are closed, you can see the tricuspid valve is a little bit apical to the mitral valve. So let's focus first on the left ventricle. You can see here more of that longitudinal movement, that myocardial excursion. And again, through all these segments, you can also see the thickening. You can see some of the, and then you can also look at the chamber contractility, so to speak, that fractional area change or fractional shortening, what people might call the EF, by just your overall sense of how much is the heart contracting and ejecting with each beat. So similar to the parasternal long axis, you can assess all three features: excursion, that longitudinal motion; thickening, right, that sort of horizontal motion; and also chamber change. You could do that on the parasternal long axis. On the parasternal shorts, you don't get excursion because you're looking at it on in a cross section. You are only able to see thickening and chamber contraction. And then if you look at the RV on this view, it's actually on this particular clip, it's unfair. I'm not giving you a good view of the RV free wall. It's important not to be fooled. If you don't see the free wall, you don't see the free wall. You cannot just assume that it's there. But let's say we'll assume that it's there for just this clip right now. So you can see this nice longitudinal motion. You can see here how this tricuspid annulus here has a lot more longitudinal motion than the mitral annulus. That's a feature of what I was saying earlier, where the RV longitudinal function is more prominent than the LV. But the thing that everyone forgets to discuss is that you still need that bellows effect, that chamber contractility. You still need to see an ejection. And sometimes in patients with severe RV dysfunction, they can still have what actually kind of looks like this normal longitudinal function, but they're actually not invaginating. The alveolar wall is not compressing inwards and is not ejecting that blood. So it's important to look to see that that chamber is narrowing as well. On this view, you can also, and here's one of your best views to get a view of mitral regurgitation, tricuspid regurgitation, by putting a color Doppler over the atrium, over the right atrium, over the left atrium. And finally, you get to the subcostal view. This is probably the best view to assess for pericardial effusion if you're working up tamponade, which again is a clinical diagnosis. You want to be sometimes this is the best view you get if patients especially have a lot of pulmonary edema. You want to be very cautious about making claims about LV function on this view because it's very, very easy to be off axis. You know that you're on axis if you're able to see the valves opening and closing, but and you're able to see both atria and both ventricles well like this. At the same time, even on this view, even when it's on axis, I would very much hesitate to make a call about LV function because you could very, very easily still be ever so slightly off. And then you're capturing sort of the sides of the wall and it looks like your EF is fantastic, and it's really not. And I believe I'll have that in a case for you also coming up. So hopefully this was, oh, I left out the IVC, forgive me. So this is why I said 4 to 5 views. This would be the 5th view. Again, we had parasternal long, parasternal short, apical 4, subcostal 4. So those are 4 views. And then if you rotate 90 degrees, you can get the IVC view. I'm not a major fan of the IVC. If it's completely collapsed, that could generally be a sign of someone who might benefit from fluids if it's otherwise safe. There's really very little else that you can tell from a basic level from the IVC. It's extremely common for people because I think it's one of the easiest things to find. It's extremely common for new learners to learn the IVC and start making claims about it, but there are a lot of really helpful articles that caution against all the mistakes that could be made from just making volume status calls from the IVC and ultrasound. So I would hesitate and I would caution everyone against doing that. So here we are, quickly just looking at these views that we just went through. And now for our last 15 minutes, I'm going to go through 4 cases. So here we go. I'm going to read it because this isn't interactive in person right now. But a 69-year-old woman with unknown past medical history is coming in with lethargy, fatigue, and shortness of breath after 5 days of just feeling unwell. She's got some chest pain, nausea, maybe some vomiting and diarrhea, maybe had some fevers at home. Over here, you find that she's perifebrile, tachycardic, hypotensive, on some oxygen just to get to 91%. And we don't know if that's a baseline oxygen requirement, and even though she's not on oxygen at home that she wasn't aware of. She's altered, has diminished breath sounds bilaterally, no murmurs, no abdominal pain, little lower extremity edema. She feels warm to the extremities, has a little leukocytosis, an elevated creatinine that you don't know if it's acute or chronic, a little bit of a lactate, NT-proBNP, a trope, and X-ray is pretty poor quality, but maybe there's a retrocardiac opacity, maybe there's right middle lobe opacifications. So if I've done a good job, your differential diagnosis here is extremely broad. You might diagnose this as undifferentiated shock, right? There's just so much that this patient can be. And if you thought about your differential and you thought about what your initial management strategies might be, well, it can vary quite widely. I made a chart of just some of them, right? This could be a patient in septic shock. Over here, I have a potential diagnosis, your supported findings, the management. So no leukocytosis, the history of feeling unwell. So that patient would get fluids, pressors, and antibiotics, right? If they're hypovolemic shock from just maybe a GI situation, then maybe just fluids. Or it could be a pneumonia and ARDS with septic shock. And you have the oxygen requirement, dyspnea, the X-ray findings, and that's a patient who you might want to prioritize pressors on over fluids if you're worried about their lungs. Or this could be a patient who has an acute PE, which explains the oxygen requirement, the dyspnea, the chest pain, the trope, the shock. This is a patient where you need anticoagulation, or maybe call your PERT team or whatever you might call that, your local team that deals with interventions for pulmonary emboli. Maybe it's cardiogenic shock. You've got the NT-proBNP, the lower extremity edema. This is a patient you're not giving fluids to, you're actually diuresing. Maybe they go to the cath lab if you're worried about an MI, right? So undifferentiated shock. These patients hopefully sounded familiar. I think these patients come into our ED every day with all these conflicting various data points and with different management strategies. So this is a situation where echo can really help guide your management. I should share, I don't think anyone should say that echo is the only thing you need. Of course it's not, but it can be very powerful in helping you guide your clinical assessment. So we go through the windows methodically. And over here you have, rather than the American Society of Echo beautiful clip that I showed you earlier, you have a more realistic clip of what things might look like in the ICU. Here you're in the parasternal long axis view again. You've got the left atrium, the left ventricle, the aortic valve, the RVOT. And what you might notice is that this patient seems to have maybe like close to 100%, so to speak. I don't want to say EF, but chamber contractility. It's not exactly the walls. This anteroseptal wall here and the infralateral wall are not perfectly touching. You have some papillary muscle here that's sort of connecting the two. But you might notice that the left ventricle doesn't seem as full as it was on the regular view that I showed you, and maybe your EF is quite high. So this is someone where on this view, what I'm noticing is what might be hyperdynamic function. I'm going to look at the other views. The RV doesn't seem to be super large to me. Then I do a parasternal short axis view. I'm only giving you this view here, which is a little bit below the papillary muscles. This is probably the apical level. It would be nice if we had other views, but sometimes you just don't get better views. The reason why it's getting bigger and smaller is not because the patient's breathing, but because whoever took this clip is actually zooming in, is increasing and decreasing the depth, which you can see on the side here. And overall here, though, at this level also seems to be quite robust LV function, symmetric LV function. And then you go to the apical four-chamber view, and we're on axis. I mean, we're slightly frame shifted, but we've got the apex at the top. We've got the ice cream cone appearance, long ventricles, atria, valves here. And again, you get the sense that the ventricles are not quite as full as you saw in the regular one, and the EF seems to be quite good. So maybe some hyperdynamic to at least normal function as well. You're certainly not seeing a blown RV. One thing I should have mentioned when you're looking at RV function on this side also, sometimes RV function presents as just a very dilated RV. And you would know that by seeing that the RV is equal in size or greater than the LV. Those would be signs of moderate or even severely enlarged RV. And then if you get an IVC view here, you can see you have a really, really razor thin IVC, and it's actually collapsing entirely maybe when the patient is breathing in. So if you're taking our 6-step approach to shock, you're thinking about all those views as you go along. If a patient here has got hyperdynamic biventricular function, so it's probably not cardiogenic shock. They've got a normal RV, so it's probably not a PE or cor pulmonale from ARDS. They've got a collapsed IVC, underfilled ventricles. So this is most likely, I shouldn't say possibly, most likely hypovolemic or septic shock, right? You've got hyperdynamic function. And so this is a patient who you're probably going to give fluids to. antibiotics too, and you're going to reassess. You're going to see what happens after a liter or two. You're going to go back and see if it looks the same or if it looks better. You're not going to flood the patient with 5 liters of fluid based on the echo, obviously, right? If there isn't an appropriate response, then you might still have to second guess your finding, right? But this helped guide your management, right? You're not calling the PERT team, not calling cardiac surgery for acute MR. What about the patient's oxygen requirement, the trope and the BNP, right? The lower extremity edema, right? Patients come in with all sorts of various findings, and part of our clinical assessment is to figure out which data points are crucial and which data points are, outliers that we're going to explain otherwise, right? They're not boards questions. And so this is one situation where the ultrasound is going to help guide your differential and your immediate management. Now, if you are trying to tease apart hypovolemic and septic shock, that could be tricky, and there might not be something you could do further with basic echo. But I wanted to put a shout out to advanced critical care echo, which can help with this, because you could measure cardiac output, measuring an LVOT VTI using spectral Doppler. These are advanced skills that I think are quite helpful at the bedside. I included in my moderate critical care ultrasound curriculum, because if you have low cardiac output, especially after you've tried some initial resuscitation, if the patient was in hypovolemic shock, it's probably still going to be low. In a patient with septic shock, it's usually a high output state, especially after initial small amounts of fluid resuscitation. And so if you have a high cardiac output, it's probably all septic. And if you have low cardiac output, it's probably more hypovolemic. You can also measure systemic vascular resistance. You can do an assessment for volume responsiveness, which is a lecture in its own right. So these are other things that advanced critical care echo can do for you. Case number 2 is the same exact case, because what I want to illustrate for you is that the ultrasound can completely change how you're going to assess the patient who looks the same on paper in EPIC, undifferentiated shock, but you put down the ultrasound and it changes what you do. All the cases will be the same. So here's a patient in a parasternal long axis view. You have the left atrium, left ventricle, and you might notice that the RV has taken over the screen here, right? Now you have to make sure that you're not just off axis. Maybe you're having what's called the RV inflow view, but here you can see the aortic valve opening and closing as well, at least at some point during the clip, the mitral valve. This is a patient who's on axis, but the RV is so enlarged that it's impinging. It's probably pushing into this LV, and the LV function itself seems to be okay. The RV is really stealing the show here. You're going to be keeping an eye on that RV as you progress through the different clips here. And so here you go in the parasternal short axis view, again, maybe slightly below the papillary muscle level, and look how large that RV is relative to the LV. The LV looks like this tiny little donut relative to the RV, and you notice that septal flattening, which seems to be happening in both systole and diastole, which is something else to learn about in your moderate to advanced career pathway. But noticing a D sign at all is a sign of the RV impinging on the LV and maybe RV dysfunction. And then you go into the apical 4-chamber view and look at that RV, which is, if you believe that this is, and you have to be careful, again, just like you have to be able to see this wall really to call LV size. But for today, if you'll believe me that this RV is larger than the LV, right? That's a sign of serious RV dysfunction. And look also how that longitudinal function, especially if you look at the annulus, when we measure that, we call that TAPSE. But even if you just eyeball it, it doesn't look terrible. And the apex here is actually invaginating too. But if you notice that, if you look for that chamber contractility, that bellows, there's actually very little change in the area of the ventricle, right? There's very little, presumably demonstrating very poor cardiac output from the right side. This specific constellation of findings where the apex is moving in, the annulus is moving, but the RV overall is not pushing in much. That's actually called McConnell's sign. But you don't have to know about McConnell's sign to recognize that this RV is large and not pushing in well. So we're very worried about the RV here. And so if we're worried about RV, right-sided heart failure and dysfunction, that has its own differential diagnosis, right? It could be a patient who has an acute pulmonary embolism. And if you happen to see this clot in transit right here, you see that clot hanging around in the left atrium and the right atrium, you're done. You've diagnosed a PE. You don't even need a CTA. You can just go on with your management, maybe calling your PERT team, et cetera. Maybe they'll want a CTA for some reason. Maybe this is core pulmonale with ARDS. Maybe the patient, right, is now having RV failure secondary to their respiratory failure. Maybe this patient had chronic PH and this is decompensated PH, which is also something to work out. Maybe they have an acute pneumothorax, which you haven't noticed yet, and that's causing some obstruction and RV failure. And so what can you do to tease these apart? So chest x-ray, ultrasound can help you with a pneumothorax, with ARDS, history of pH. It can help you clue in if there's some pH in the background. There are advanced echo measurements to help you tease apart if somebody might have a component of chronic PH. And like I mentioned, a colon in transit or a lower extremity vascular exam can help you identify a DVT, which could increase your likelihood of a PE. So to summarize our findings here, you've got normal LV function, a severely dilated RV with septal flattening with a clot in transit. So this is a patient who's almost certainly a PE, no effusion, normal valves, which I didn't show you color, but you'll believe me, and has a dilated IVC. They're not hypovolemic. So this is a patient where you're going through your PE pathway. Third case, same case, different ultrasound. So here's a patient. I'm going to go through this a little bit more quickly because we're running on the clock. This is a parasternal lung axis view that is really off axis. Look at that fake apex here. You have the left atrium, the aorta, but you have like what almost looks like an apex. We're so off axis, we really shouldn't say anything too much about this case here. You might notice a little pericardial effusion up top over here. But you might notice maybe that the aortic valve is a little thick, but very limited view. But this is just the reality of what you might get in the MICU. Ignore these yellow lines, and forgive that my depth is so deep. These would have been really beautiful clips if I didn't do those two things. But here you have the parasternal short at the aortic valve level. The aortic valve, actually, this is a little bit beyond basic echo, but isn't opening so robustly. But overall, this looks normal. Here too, you've got symmetric circular LV function. It's functioning pretty well. This is at the mitral valve level. You go to the papillary muscle level and same thing. The muscle's thickening. The RV doesn't look big. It's coming in symmetrically. So far, everything is looking quite good. Now you go to the apical four-chamber view. And again, we're not able to see the RV free wall, so limited view. But so far, we didn't have any concerns from the other views. Here you have the LV. It's contracting nicely. It's thickening. It has longitudinal excursion. And overall, it's looking quite good as well. So you pick up the probe and you have a patient who's in shock, and that's what you find. And so what you're seeing is normal BIV function, so it's probably not cardiogenic shock, a normal RV without pericardial effusion, or I should say without a huge pericardial effusion. So I didn't show you a subcostal, which I should have, but unlikely to be a PE or a core pulmonale from ARDS or other obstructive shock. You've got a normal IVC, take my word for it, and ventricular diastolic size, so it's probably not hypovolemic shock. Maybe there's suboptimal aortic valve opening. So this isn't really giving us much of an answer. And the truth is, so overall here, what you have is what looks like a normal appearing shock, echo in shock. And this happens very frequently, right? I go through this talk as if like every time you put on your echo, you're going to have the magical answer. And I think usually more often than not in a medical ICU, this is what you'll find. And it's usually because you have an etiology that's non-obstructive, non-cardiogenic, and probably a combination of hypovolemia, sepsis, sedation, right? And when that happens, you put down your probe and you go on with your day. You didn't rule out acute tamponade. You did rule out acute tamponade, acute RV failure, et cetera. And that's useful information. It might take you 5 minutes to do. Now that's an intermission from this case, because in this case, I wanted to show you how we can start incorporating other lung ultrasound findings. And here you put the lung ultrasound on, and you see that in the right middle lungs, and you've got B lines. This is a sign of edema, usually. Everywhere else you have A lines. This is normal lung. So you've got focal B lines. That's either a sign of infection, or for whatever reason, you've got edema in just one spot, which would be a strange thing ordinarily. But then on all these cases, I didn't give you color. But what if I start giving you color? Well, if we go back to that parasternal long axis view that was off axis, still, if you put color on it, you can see that there's some MR, some of that blue that's going backwards. And it might not look like much, and you can't really grade it, especially from the parasternal long axis view, but it clues you in to look at it in the apical four-chamber. You look in the apical four-chamber, and here you have rip-roaring MR, which might look less than it actually is because it has this Coanda effect where it's wrapping around the left atrium. Major MR, right? So this is a patient where if you didn't put color on, it just looks like a normal echo, normal EF. And what you didn't notice is that all the EF was going backwards, right? And that can be a major problem, certainly if it's acute MR, right? And so this is a patient who had normal appearing biventricular function without effusion, but has severe MR, right? That also might explain why the aortic valve wasn't opening as well, because while the EF was great, the EF was all regurgitant, right? A lot of it was just going backwards. This is a patient where you need to call your cardiology, your heart center, you need to think about mechanical circulatory support. If you have acute MR, of course, it could be chronic, so it's more helpful if you had a previous echo. You have to use your judgment in determining whether or not you think it's acute. But Really, really important to rule out acute MR in anyone who's in the ICU with shock. Don't forget to put color on. Don't forget the color. Don't forget to rule out valvular disease. These patients can look like liver failure. They can look like septic shock until you put the color on. In the interest of time, I'm going to skip case 4. It was a case of Takotsubo cardiomyopathy, where you're going to notice the majority of the dysfunction sort of at the bases, at the apex, forgive me, where it sort of balloons out. But I'm going to move on from that. I think we've more than covered the very basics, and I don't want to overwhelm or stuff anything into the very last case. So in conclusion, remember to look through your windows methodically, track your findings, know what you can see in each view, know what you're not finding in each view, summarize to find a diagnosis. Don't forget the extra cardiac assessment, make decisions and follow them. Incorporate the other organ findings, know your limitations, and believe. And really the most important thing more than believing is reps. Just practice and repeat. Thank you very much.